Hi, I'm Steve Schuster from Abramson Cancer Center at the University of Pennsylvania in Philadelphia. And joining me today for what will be a lively discussion are my friends and colleagues, Matt Fergal from the MGH in Boston, Karen Jacobson from Dana-Farber in Boston, the competing institution with Matt, David Miklos from Stanford, and Loretta Nastapel from Texas at MD Anderson Cancer Center. What we're going to discuss today are a number of topics related to the use of CAR T cells in patients with lymphoma, and we'll probably be making reference to ALL as well, because that was some of the earliest data. Some of us have some experience, but most of us are primarily treating lymphoma patients right now. And we'll talk about some of the latest stuff that's out there, some of which was presented in December at the American Society of Hematology meeting, and most recently at the meeting that just happened, which is ASCO. So without further ado, I'll move on and we'll talk about the first topic. This is going to be a bit free-form in our approach to discussion. So we'll focus first on lymphoma, and if time permits, we'll talk in more detail about leukemia, but I think that some of the leukemia data will come out as we discuss lymphoma and we compare and contrast diseases that are treated with the same agent but with different outcomes. All right, so the first question on the list was, what is the rationale for CAR T cell therapy? And I think that any one of us could weigh in on that, but I think that we know that it's approved for diffuse large B-cell lymphoma, so there must have been a need if the FDA approved it. But where are we going? What do you guys think is the rationale for further development of this beyond diffuse large B-cell lymphoma? Because I think there's going to be some developments this year and even maybe next year that also are bearing on lymphoma. Who wants to weigh in on that?
I think it's one of the first therapies we've actually brought to the market that's a cellular gene therapy, first off, which is pretty exciting. And so getting over huge barriers there in terms of technology and regulatory hurdles. And so we've only really been seeing it accelerate, but as remarkable as the responses have been, I think there's still room to go and ways to improve the technology, whether it be from an efficacy standpoint, toxicity standpoint, or just getting more access to patients.
Yeah, I agree completely. I mean, what you're seeing right now are, the first generation cars, the Model Ts. It's going to get better and better and better. And every manufacturer is going to say that they make the best car, So that's just what happens in Detroit and everywhere else, right?
And if we consider what happens when the patient has progression or relapse after R-CHOP induction chemotherapy, and the numbers of other things that we call salvage on a goal towards going to a high-dose stem cell transplant with, at best, 50% response to salvage and 50% durable responses after auto. We can help so many patients by bringing an effective immune therapy forward, if for no other reason than what they endure going through mobilization, salvage chemotherapy, and an auto transplant, which if you add it up is 5 months of their lives right there, yet alone the problem of median time to survival of patients who have relapsed refractory chemo-resistant lymphoma being only 5 to 6 months. I mean, so right away.
So there's two very important points in what you just said, David, and I'm going to just reiterate them because I think they're really important points. First of all is that there's patients that would not be candidates for auto transplant that are candidates for CAR T, and this relates to patients that are elderly and even with comorbidities, because it's a heck of a lot easier on patients, as we've learned, nowadays, than high-dose chemotherapy can be. So yes, this is a benefit for those patients. We'll wait for additional studies to see if we can move it right up to second line for some groups of patients that are not transplant eligible. And second of all is that, as you said, our ability to salvage patients with auto transplant in the immunochemotherapy era, has dropped significantly. I mean, I remember when we first started doing auto transplants in the late 1980s prior to rituximab, and I'm telling you, 50% of the patients were fixed. Okay, And I think in the current era, with rituximab, and particularly those that fail within the first year of receiving a rituximab-containing induction regimen, the outcome with second-line chemotherapy and auto transplants kind of abysmal. So that's the other big niche for CAR T in aggressive lymphoma.